Good evening. This is Dr. Lawrence F. Jindra. I am fortunate to be able to speak to you tonight about long-term results with selective laser trabeculoplasty as primary, secondary, and repeat therapy. I wish to note that any of the studies presented during this presentation were independently conducted and financed through the revenue generated by my medical practice. I have not received any support from industry for these research studies. I have received honoraria from Ellex Corporation in the past year for speaking at events like this. The title of this presentation is SLT is not ALT Lite. What is SLT? SLT uses a Q-switched frequency-doubled neodymium YAG laser tuned at 532 nanometers. It is called selective because the procedure targets preferentially melanocytes in the posterior pigmented trabecular meshwork. I should point out the SLT laser has 1/6,000 the flux density of argon laser trabeculoplasty. Hence the assertion that SLT is not ALT Lite. When SLT is performed, a biologic response is induced, which involves the release of cytokines and triggers systemic macrophage recruitment, which causes a remodeling of the trabecular meshwork and a low-grade inflammation, which ultimately results in a reduction in intraocular pressure. The method of action is thought to be selective photothermolysis. Only the pigmented cells are targeted. Because only the pigmented cells are targeted and there is such a low flux density of the laser, there is a minimal risk of the laser inducing peripheral anterior synechia. Because of the method of action of SLT, there is no thermal nor coagulative damage to surrounding tissue. SLT is not ALT Lite. Many practitioners, when they start considering SLT for their patients with glaucoma, when they consider treatment, they make the mistake of thinking they are performing argon laser trabeculoplasty. We had a junior faculty member at Columbia who did not understand this, and she performed SLT in quadrants with very low energy, without seeing the required response, without treating at the appropriate energy, and she did not get a response. That is because she was thinking of SLT as ALT Lite. It is not. SLT uses very low energy. It is a cold laser. It does not cut. It does not burn. It does not scar. And you must get in that mindset. It is a different kind of laser trabeculoplasty. Let's talk about some of the research that supports why we use SLT as treatment for glaucoma. The glaucoma laser trial, which was conducted between 1989 and 1996, established the efficacy of laser trabeculoplasty to lower intraocular pressure in patients with untreated primary open-angle glaucoma. In other words, first-line therapy. The ocular hypertensive treatment study treated patients. Let me back up. The ocular hypertensive treatment study showed that treated patients had half the risk of developing early glaucoma. This study established the fact that early treatment prevents or delays the onset of glaucoma. This study established the efficacy for early treatment to preserve long-term vision in patients with glaucoma. The early manifest glaucoma trial, conducted at about the same time in Europe, showed that treatment reduced the risk of developing significant glaucoma. Effective lowering of intraocular pressure in newly diagnosed patients with glaucoma slowed the progression of visual field loss. The early manifest glaucoma trial established the efficacy of effective treatment to preserve long-term vision in patients with glaucoma. How do we treat patients with SLT? Well, there are several things to remember. First, the focus of the spot is not critical. You are not performing ALT. You are not using a non-collimated beam. The SLT beam is itself already collimated. There is no need to have the helium neon red spot aiming beam in focus. However, you must visualize the trabecular meshwork to treat the trabecular meshwork. You must perform an adequate treatment. An adequate treatment is such that the end point of treatment causes the visualization of champagne-like bubbles. You must titrate the energy with the pigment in the eye, meaning patients with blue eyes and less pigment need more energy. Patients with brown eyes need, I said that wrong. Patients with blue eyes and less pigment need more energy. Patients with brown eyes and more pigment need less energy. You must perform an adequate treatment for the laser to be effective. We found at least 120 spots is helpful. The treatment area should be at least 240 to 360 degrees. We recommend using post-op nonsteroidal anti-inflammatory drops daily for 3 days. We do not use steroids. There was some work that showed the steroid receptor and the inflammatory receptor were one and the same, and we didn't want to blunt the postoperative low-grade inflammatory response. I would recommend in treating patients who are on multiple medications to taper the medication slowly and remove the prostaglandins first. The reason we remove prostaglandins first is we have a synergistic response between the laser and the prostaglandin. Prostaglandins and SLT work by the same method of action, namely a low-grade inflammatory response. Prostaglandins and SLT can both be thought of as outflow drugs, so we remove the outflow drug after the outflow treatment is performed. We pre-treat with bromonidine and bromfenac one time 10 minutes before the procedure. For initial treatment, for either primary treatment, meaning the patient is medication naive, or secondary treatment, meaning the patient is on medication, we treat between 0.4 and 1.8 millijoules. The spot size is fixed at 400 microns. Treat between 110 and 130 spots. I treat for 240 degrees between clock hour 2 and clock hour 10, leaving the top 4 hours untreated, and the end point is for champagne bubbles to be visualized. I started this procedure back in 2001, and I had converted to non-perforating trabeculectomy about 5 years before that. And with ALT, we did not treat the top 4 clock hours. I continued doing that with SLT, and it have gotten good results, so I have not changed to 360. For repeat treatment, we increase the energy a little bit to 0.6 to 2.0 millijoules. The spot size is the same. The number of spots is the same. The area of treatment is the same, and the end point is the same. I said before how we should titrate the energy with the pigment of the trabecular meshwork. For very dark black irides or patients with pigmentary glaucoma, we want to start very low. For pigmentary glaucoma, we start at 0.4, and I would rarely treat a patient with pigmentary glaucoma above 0.8. For patients with dark black irides, I would start the treatment between 0.4 and 1.0 and titrate the energy to the observed response. If you get an observed champagne bubble reaction at low energy, I would stay at that low energy. Brown-eyed patients, I start between 1.0 and 1.2 and titrate up or down as needed. Green-eyed patients, 1.2 and 1.4. And blue-eyed patients, 1.4 to 1.8, and titrate up or down as needed. In patients with exfoliative glaucoma with slate blue irides, you will treat at the higher end of the spectrum, at least 1.6 to 1.8. Postoperatively, we use bromfenac once a day for 3 days after initial treatment, once a day for 5 days after repeat treatment. So what are some pitfalls? Do not undertreat. Blue-eyed patients need more energy, and you increase the energy until you see the champagne bubbles. Patients with exfoliative glaucoma and very light irides need even more energy often. Conversely, we do not want to overtreat. Brown-eyed patients need less energy. Pigmentary glaucoma patients need far less energy. You do not want to cause a postoperative pressure spike. You do not want to cause excessive inflammation and anterior chamber iritis. I find that NSAIDs are important for patient comfort, and you also want to taper medications slowly on initial treatment of secondary treatment patients. That means initial treatment of patients who are on medications, because you want to avoid a rebound spike of intraocular pressure. When you begin SLT, or as you're doing SLT, keep in mind SLT is an outflow drug. If you would use prostaglandin drops to treat, then you can use SLT to treat. I'd like to talk about several studies we recently presented involving our 4,000-eye data set. The purpose of the study was to examine and evaluate SLT as primary therapy to decrease intraocular pressure in patients with glaucoma. A retrospective chart review was performed on almost 2,000 of these almost 4,000 eyes, treated with SLT over a 10-year time period. A two-tailed pair t-test was used to compare maximum pre- and average post-procedure intraocular pressure. Mean follow-up was approximately 3 years. The mean IOP decreased 29% from a mean of 18.1 to a mean of 12.8 millimeters of mercury. This reduction in intraocular pressure has stayed very constant between 30% and 33% throughout the course of our evaluation starting in 2002. And these results were significant statistically. We also performed an actuarial procedure called Kaplan-Meier life table analysis to determine the cumulative probability of success. You see in this procedure the cumulative probability of success ranges from 98 to 90% at 10 years. The next study I wish to talk about, it was designed to evaluate SLT as secondary therapy to decrease intraocular pressure and reduce medication in those patients who are or were treated with medications previously in patients with glaucoma. A retrospective chart review was performed on a little over 1,000 eyes. out of the 4,000 eye data set, and this was also in patients treated with SLT over 10 years. We performed a two-tail paired t-test to compare maximum pre and average post-procedure IOP, as well as the number of medications pre and post-procedure. Mean follow-up was a little bit less than 2 years. Mean IOP decreased about 22% in these patients, from a mean of 19.6 to a mean of 15.2 millimeters of mercury. Mean meds decreased by 86% from a mean of 2.2 to 0.3 meds. The results were statistically significant. This is the cumulative probability of success for SLT as secondary therapy. And you see at 10 years, the cumulative probability of success was 88%. One of the hallmarks of SLT, in addition to its efficacy and its longevity, is the ability to repeat. We evaluated SLT as repeat therapy to decrease intraocular pressure and reduce medications used in patients with glaucoma. Retrospective chart review was performed on almost 800 uniquely treated eyes from 3,000, a little over 3,000 uniquely treated eyes from the 4,000 eye data set of patients treated with SLT over 10 years. The same t-test for statistical significance on intraocular pressure and medication that was performed in the secondary study was performed in the repeat study. For primary repeat SLT, in other words, patients who were medication naive, who were treated with SLT and who did not meet their goal pressure, mean follow-up was over 3 years. Less than 3 years. Mean IOP drop was 22%, and the cumulative probability of success at 7 years was 77%. And the prevalence of repeat over 7 years was 9%. For secondary repeat SLT, for those patients who were on medication, who were referred into my practice, and I should note, since the glaucoma laser trial published its final paper in 1996, I have not used medication except in very rare occasions when the patient specifically requested as initial treatment of glaucoma. So those over 1,000 patients who were treated were referred into my practice for treatment. Mean follow-up in this data set was approximately 2 years. The mean intraocular pressure drop was 22%. The mean medication change was plus 0.1 medication. The cumulative probability of success at 7 years was 63%. And the prevalence of repeat treatment of secondary SLT over 7 years was 10%. The cumulative probability of success of repeat SLT for initial treatment being primary treatment, in other words, the initial treatment was treatment with SLT instead of drops, varied between 98 down to 77% at 7 years. We did not have enough patients after that time to perform meaningful calculations. For secondary repeat treatment by SLT, the cumulative probability of success varied from 95 down to 63% at 9 years. Caveats to take home from this presentation. SLT is not ALT Lite. It is not a coagulative nor a destructive form of laser trabeculoplasty. It is a cold laser that does not cut, does not burn, does not scar, and works on the cellular level to cause remodeling of the trabecular meshwork to result in a decrease in intraocular pressure. Due to the inflammation that is created, you can think of SLT as an outflow drug. The focus of the spot, due to its already collimated beam, is not critical, but you must visualize the trabecular meshwork. So if you're treating with a patient, if you're treating a patient with narrow angles, you should ask them to look in the direction of the mirror and cant the mirror in the direction of the angle to open the angle as much as possible. You want to treat the trabecular meshwork. In these patients, you have to be very careful not to hit the ciliary body band or the iris because the patient will feel that, but you must treat the trabecular meshwork. The treatment endpoint should be and must be the visualization and the creation of champagne bubbles. If you don't use enough energy, you will not get treatment. You want to be careful not to use too much energy, however, because that will result in discomfiture for the patient and a risk of intraocular pressure spikes. You do not wish to undertreat blue-eyed patients with exfoliative glaucoma because it will result in an ineffective treatment. You do not wish to overtreat brown eyes or patients with pigmentary glaucoma syndrome because that will result in iritis and discomfort to the patient as well as a postoperative pressure spike. You need to treat. Treating a quadrant with 20 or 30 spots is not a treatment. You need to treat with 120 spots over 240 to 360 degrees. I recommend you use postoperative nonsteroidal anti-inflammatory drops for at least 3 days for patient comfort. In patients, especially the secondary patients who are already on medications, taper the medication slowly. By that I mean, before you declare SLT ineffective, you need to wait at least 2 to 3 months for all the late responders to respond. At that point, I recommend when you taper the medications, you do it slowly. I typically remove the prostaglandin first. Then, because of the side effects of red eyes, I remove the alpha agonist second. I remove the carbonic anhydrase inhibitor third, and I remove the beta blocker last. I wait 1 month between each reduction in medications to allow the eye to adjust and to observe the intraocular pressure. Particularly, I recommend you be aware of late responders because patients who've had the laser may be very interested in the results of their intraocular pressure, and no change at 4 weeks or 6 weeks is not an omen of failure. Wait the full 2 to 3 months. In review, the glaucoma laser trial established the efficacy of laser trabeculoplasty to lower intraocular pressure in previously untreated glaucoma patients. So the glaucoma laser trial established the efficacy of argon laser trabeculoplasty as primary treatment in patients with glaucoma. That study showed in patients treated first with ALT using 4 indicators: visual acuity, visual field, intraocular pressure, and use of medication. ALT worked as well or better than medications available at that time. The ocular hypertensive treatment study and the early manifest glaucoma trial together established the efficacy of early and effective treatment to preserve and protect long-term visual function in patients with glaucoma. The data that I presented to you tonight on our studies build on these findings and demonstrate that SLT significantly lowers and maintains a decreased intraocular pressure with cumulative probability of success for both primary and secondary treatment at approximately 90% over the long term. This is in eyes treated with SLT as primary and secondary therapy. For repeat therapy, the cumulative probability of success is less. In my opinion, similar to Ridley's intraocular lenses, Balazs's use of viscoelastics, and Kelman's discovery of phacoemulsification for the treatment of cataracts, I personally believe Mark Latina's discovery of selective laser trabeculoplasty may someday be recognized as the single greatest step we have as clinicians for the treatment of glaucoma. I thank you for your attention during this presentation, and now we'll look at the questions that we have presented to us. The first question is, how long does the laser work? Using actuarial principles, the cumulative probability of success for SLT as primary therapy over 10 years was 90%, and SLT as secondary therapy for a comparable amount of time was 88%. The next question. I apologize, I thought. Can the laser be repeated? Yes, SLT, in contrast to ALT, can be safely repeated. Keep in mind, there were studies that were published that showed the efficacy of repeat ALT was in the single-digit teens, 11 or 13%, depending on the study. There was a rule of thumb that 30% of patients with ALT failed after 3 years and 10% of patients failed each year thereafter, making a 50% failure rate at approximately 5 years. The studies that we presented using our 4,000-eye data set show a much greater efficacy of result of treatment with SLT over a long time period, up to 10 years. While it is not a scientific study, anecdotally, I had 3 patients in one morning last week, one who I had treated at 9.5 years, and 2 who I had treated at almost 10.5 years, all 3 of whom had 1 laser treatment, all 3 of which were primary therapy, meaning the patients were medication naive, all 3 of which had both eyes in goal after 9.5 to 10.5 years. The next question. Should the laser be done before medication is used? Well, if you believe, and I think the data are significant to believe the glaucoma laser trial, and if you believe the growing body of evidence that is now being presented at conferences that are peer-reviewed the world over, primary use of SLT as initial therapy for patients with previously untreated primary open-angle glaucoma is getting bigger and bigger and more widespread. If you think of SLT as an outflow drug, as a non-destructive cold laser, there does not really seem to be any contraindication or any reason not to do SLT in the overwhelming majority of patients newly diagnosed with primary open-angle glaucoma, exfoliative glaucoma, or pigmentary glaucoma. I would be careful with inflammatory glaucoma, neovascular glaucoma. I wouldn't lump them into that group. But in patients with those glaucomas, treating with SLT as primary therapy is very beneficial. Where does MLT come into play versus SLT and ALT? I have not seen a published study that compares all three head-to-head. What I do know about MLT is that it is a minimally destructive laser, and it works more in the mode of ALT than SLT. I have not treated any patients personally with MLT. I personally, when I read all the papers when it first came out, I didn't see any justification to take half a step backwards. I think the technology behind selective laser trabeculoplasty is superior to that for MLT, and in my opinion, I did not see any reason to do that therapy. Regarding the probability of success after 10 years, what defined the probability of success? Perhaps it was a specific percentage of intraocular pressure reduction. That's a very good question. For primary therapy, the definition of failure was the patient was not within their goal treatment set before the laser. I'm a firm believer in setting target pressures and working towards getting to that target pressure. If a patient's medical condition changes, if they are newly diagnosed with diabetes that they did not have before, if they suffer a branch retinal vein occlusion, of course it is permissible to set a lower goal pressure. But we set the pressure based on the patient's full medical and ophthalmic history, taking into account family history, race, corneal thickness, presence or absence of small vessel disease, including but not limited to diabetes, hypertension, collagen vascular disease, use of nicotine, use of caffeine, and set a goal pressure. If the patient did not meet that goal pressure and they needed either a repeat laser or they needed medication to get them in their goal pressure, they were classified as a failure of primary therapy. For secondary therapy, the definition of failure for SLT is far more robust than ALT. Nobody wanted to treat with ALT anyway a second time, and if you did do it, it was predominantly because the pressure was out of goal. With SLT, you can be more robust. If a patient is in goal and they are on multiple medications or they have red eyes, in the ALT era, nobody would retreat that patient because they're in goal. In the SLT era, you can retreat them. If they are in goal and they have red eyes, or if they have systemic side effects from the medications. Or some patients, they are in goal and they're not having side effects to the medications, but they just don't want to use the medications. It's perfectly acceptable for them to try to get off the medication. I can tell you many patients who we treated with SLT who were taken off their medications and were on no medications. And we presented a paper a few years ago that showed patients on one medication, 86% of them successfully got to zero medications and stayed at zero medication for the 5 years of the course of the study. Those on two medications, it dropped down to 62%. Those on three medications were 45%. Those on four medications were 34%. So when patients are off medication and a few years go by and their pressure goes up and it can be controlled with one drop, many of them will say, I don't want the drop, do the laser again. So that was the definition of failure. For secondary treatment, it was more robust. The patient either was out of goal, had side effects not congruent with their quality of life, or they were not in goal, they were in goal but were on a medication, or out of goal and needed a medication and didn't want the medication and were instead treated with SLT. The next question is, does SLT work in pseudofakes? Yes, we presented a paper at ARVO and a paper at AAO that showed SLT is significantly effective in pseudofakes. I find it, if you have a patient who is under borderline control and you're concerned that the effects of cataract surgery or steroids that you might have to use, or the inflammation after cataract surgery, if you're concerned that the surgery or the side effects of the surgery or the medications of the surgery may cause an untenable rise in intraocular pressure, pre-treatment with SLT has proven to be a very good and very useful tool to reduce intraocular pressure and reduce those complications. Have you seen or heard of any additional irritation or complication from doing 360 as opposed to 180? Well, I'll answer that question in two parts. I have seen studies that have shown 180 is ineffective. So besides the additional irritation, from an efficacy point of view, 180 oftentimes is not enough trabecular meshwork to cause treatment. Treating 180 goes back to the old ALT trabeculodestructive days, and since we said SLT is not ALT Lite, I think there's no reason to only treat 180. As far as additional irritation, when you titrate correctly the pigment to the champagne bubbles, using as little energy as possible delivered to cause the response of the champagne bubbles at the level of the trabecular meshwork, the level of irritation is minimal. The use of nonsteroidal anti-inflammatory drops for initial treatment, primary and secondary, or 5 days for repeat treatment has mitigated that. I know in some parts of the country, patients are not treated at all, and from what I understand, they experience minimal discomfort. I treat for 3 days with a once-a-day NSAID for patient comfort. Do I see a time when insurance will opt for SLT versus generic drops? Is there an economic advantage to SLT? I was privileged about 20 years ago to be selected as a White House Fellow, and I worked on the first major health care reform effort. I know that that is a societal consideration. I prefer not to speak as a policymaker tonight and speak as a physician. I think the insurance companies will do whatever is cheaper for them. I can tell you that I had a very large health insurance plan in the New York area refer me many, many patients for the first 5 years, and then they realized that they, instead of paying me an out-of-network fee to perform the procedure for them, it was more effective for their beneficiaries to have the SLT performed by their own physicians rather than prescribing drops or referring them to me. So if that one example answers the question, I think insurance companies would prefer effective care that results in the least cost. Is there an economic advantage to SLT? I know there have been several papers published about that, and there is an economic advantage. Anecdotally, I have a patient who was referred to me who's an accountant. What he did, it would probably take me several hours to figure out, but I treated him in late 2001. He's still in goal. He figured out that the cost of medications, the cost of lost time, the cost of gasoline to commute to my office from Eastern Long Island, the interest that he would gain on investing in a certain type of an investment. And you add all of that up over 10 years, he claims I put over $26,000 into his pocket. So yes, I think there's an economic advantage to SLT, but to both the patient, to the healthcare system, and to society as a whole. Here's a study you mentioned about 180 treatment. Selective laser trabeculoplasty had an overall low success rate in our tertiary clinic with overall failure rates of 68 to 74% in those who underwent 180 degrees of selective laser trabeculoplasty. That is consistent with what I have seen in published literature. 180 is ineffective. I cannot comment on that study because I haven't seen the treatment parameters, just like that young attending we had at Columbia who didn't understand the difference between SLT and ALT and undertreated both in energy and in spots. I can't comment on that. One thing that would be helpful to know is the total energy delivered. What is the total energy delivered in the 180-degree study? Did they titrate energy to pigment? Did they get champagne bubbles? Did they, in fact, institute a therapeutic response? Who was performing the treatment? Was it residents? Was it fellows? Was it attendings? If they were not attendings, was it supervised? If they were attendings, were they glaucoma specialists? Were they general ophthalmologists? Were they people who had experience with SLT or not? There are a lot of variables in that question, but the point is well taken that in 180 or in under treatment, you will not get the success. Does anybody have any more questions that let me rephrase that. If anybody has any more questions they wish to submit, please do so now. I'll give everybody 1 minute or so if they have any questions to submit. While people are submitting the questions, I certainly want to thank everyone who attended this evening, who has an interest in SLT. I certainly would like to thank all of those people who are embracing this technique. I would speak to some of the older people in the room who lived through it, and some of the younger people, well, not in the cyber room, I should say, who read about when surgeons converted from intracapsular to extracapsular reaction, or when they converted from extracapsular surgery to phacoemulsification. There was a lot of doubt in the beginning, but I don't know how many people practicing today who routinely do 7-minute simple phacoemulsification cataract extractions would willingly go backward in time and in technology and do intracapsular or extracapsular surgery. So I thank all of you for embracing the frontier of glaucoma. I thank all of the people who submitted questions. I thank you for your attention tonight, and I wish you all good luck as you embrace selective laser trabeculoplasty for the primary, secondary, and repeat treatment of glaucoma. Thank you and good evening.